Thank you. I think that's it. Thank you.
Thank you, sir, for your excellent presentation. There was only just some internet problem. Otherwise, I think it's a great learning activity for us as well as for all juniors who are watching this. And from our panelists, I love to Dr. Amir Khan.
Assalamu alaikum.
How are you, sir? Nice to see you.
Thank you very much. Assalamu alaikum. Great to see all of you, especially Ghulam Sadiq. Thanks very much for showing us your face. You've recovered well by the look of it. And thanks Allah to have you all back with us. It's been a great talk. I've really enjoyed your presentation and a very good review of the sleeve. Over the years, I've changed my practice quite a lot, to be honest with you. I still feel sleeve has got a role to play, and mainly for super obese, because one of the reasons what I find over the years is that super obese can never come to an ideal weight with one operation, right? And for them, you require a second stage operation. And for that, I think sleeve is probably the best one, because that gives you an option for a second stage operation. Whereas, especially with the bypass, with the Roux-en-Y bypass, you burn your boats. And after the first operation, it's very difficult to do the second one. I know people have done restrictions on them and all sorts of things, but to be honest with you, they do not work. Even by lengthening the biliary limb, it doesn't make a huge difference. So I think for super obese, sleeve is an ideal operation as a first operation of choice, because it's got a less morbidity and less mortality from point of view. Technically, it becomes easier to do as well. So I think if you do that, and then I always tell my patients with the super obese that after a couple of years, we'll review the situation. If you have not come down to an ideal weight or your diabetes have not resolved, then I'll add a bypass to that. So I think that is in my practice now, that is the main place for sleeve. I think the only group I would not offer sleeve would be the one who are either chronic smokers or the ones with the reflux GERD, because I think they become more difficult to manage afterwards with sleeve.
Thank you, Dr. Amir Khan. I came across a couple of cases where what we call a hostile abdomen. I planned the patient for RYGB, and when I went in there, it was a nightmare. I couldn't dissect the bowel, and because of previous adhesions, or one patient had congenital malformation, the bowel was sort of wrapped in an envelope of momentum, and it was quite difficult. So I had to do sleeve gastrectomy and then came out. But you never win. I did one patient who was for bypass. She had a huge hernia. So what I spoke to her was, and the hernia was containing almost half of the momentum. She was obese. So I did a sleeve gastrectomy on her and told her that we will fix her hernia after a year or so, if it's not giving you any trouble. What happened was, I was sick with COVID, and she came in emergency with small bowel obstruction. And my colleague treated her conservatively for a day, but she was really in pain. So he had to do a hernia repair. Another case where I did a bypass, but I noticed a very small hernia near the umbilicus. So I said, lage haathon isko bhi fix kar lete hain. 2 दिन तक patient was fine. Third day pe, the patient had symptoms of small bowel obstruction or severe pain near the umbilicus. So I had to take her to theater again, and there was a knuckle of small bowel stuck in that place which I repaired, and actually the sutures had snapped altogether. So sort of game.
Ji. Hello. I think Ghulam Sahab, Sudi Sahab, you mentioned a very right thing there, because if you, even in my consent forms, whenever I'm consenting patients for bypass, I always put plus minus sleeve. And that's the main
Good.
reason, because what I do is when I put a laparoscope in, the first thing I look for is whether the bowel is mobile or not, and are there any adhesions or not. So I think it is. I think most of you might agree with me that I think we need to have all sorts of tools in our armament, because you don't know which one you're going to need for the operation for that particular patient, and one need to be able to convert to that one. And swallow the pride, because I can see Javed as well. Assalamu alaikum, Javed. No. So I think sleeve is not going to die. It is an operation which is going to stay there, and there will be patients who will require sleeve, but just we need to be selective.
Great. Thank you.
You there.
Javed, welcome back.
Thank you. I had a chance to come out of the operation for 10-15 minutes.
So is
I hope your patient is not bleeding.
I've got a very able trainee. He's going to do this bit, and I thought I'll come and say hello to everyone.
No, Javed, it's great to see you.
Good to see you, Mir Bhai. How are you?
Not bad. It's just too early. I missed some of the talks. I just joined at the tail end of your talk. So I'm sorry, guys. I missed some of the very important talks. Is this program recorded or not?
Yes, it is recorded. We'll just send you on the...
Please do send us a link so we can have a look at that. Thank you very much.
We'll have panel discussion just shortly after my presentation. I'm just going to present SASI now.
Okay,
so
great, excellent. Love to see the results.
Yeah, you'll see the result. I have got a paper of 200 cases now.
Very good, mashallah.
Assalamu alaikum, everyone. And it's really a pleasure for me to be at this forum and hosting. And all of my friends from different parts of the world, they have joined this discussion. And I think definitely we and all juniors and other, they are getting a lot of benefit because of these are the legends who have done so many procedures in their life. Professor Amir Khan, Dr. Javed Raza, Professor Farooq Afzal, Professor Ghulam Sadiq, and there are a lot of others who are watching. Professor Abul Fazal will have his remarks after my presentation. He's actually the chairman of this scientific conference. As Professor Mumtaz Meher, he got COVID and he wasn't well. Alhamdulillah, he has been recovering smoothly, and all our prayers for him. And we have got a message. We'll just play that message at the end of our session. So I'm going to start about SASI, the single anastomosis sleeve ileal bypass. And alhamdulillah, I was doing sleeve for so many years, almost 10 years. Then I switched to SASI. Up till now, in 2 years, we have got a promising result. I'll tell you how many cases we have done, what are the complications, and how we choose and what are the criteria to do SASI operation. So as everybody knows, and this obesity, I don't want to go into detail. For our population, we need to have anybody who have got a BMI more than 30 with comorbidities and 35 without comorbidities. And now even those who have got uncontrolled diabetes, we can do these kinds of procedures. Somebody who have got a 27.5 or more BMI with uncontrolled diabetes, we can offer these procedures to them. So these are the procedures mostly practiced all over the world. This gastric banding, it has been obsoleted, and in very few cases we use bands. Roux-en-Y gastric bypass procedure of the gold standard procedure, and obviously it has got certain limitation. But in our population, what I have seen, these people, they used to have a lot of malabsorption. So anybody who is totally fit into that criteria, I offer bypass to those people. Sleeve gastrectomy, obviously best and commonly performed operation all over the world. More than 70% of the procedures all over the world is sleeve gastrectomy. It has got excellent results. Always you have to start with sleeve, and as I've done, so we have got very promising result with sleeve, and it depends how you perform your sleeve and how you have proper follow-up. And secondly, as Professor Mihir has mentioned, that if you want to operate on a super obese patient, you always have got a choice so that you can revert it later on if you gain weight into MGB, OAGB, or one-way gastric bypass or duodenal surgery. OAGB, MGB, it has since last few years, 2-3 years, it has got promising results. Previously, Imran, he was doing a lot, and since Rutledge came here in Pakistan, Dr. Atif, he's doing, and a lot of other people, Professor Mumtaz also have started. I have done almost 50 procedures in last few months, and it has got good results, but in selected cases, we cannot offer any procedure to any patient. We cannot say that this is best for him. We have to evaluate and then properly design a procedure for that patient. You have got SASI. SASI, very few people are doing this procedure in the world, and what we have seen, we have got very promising and excellent results. SADI, a lot of people now have started SADI, and in redo cases, SADI, single anastomosis, duodenal bypass, it has got very promising results. So what is SASI? It is a new metabolic procedure in which a sleeve gastrectomy is followed by the side-to-side gastro-ileal anastomosis. So laparoscopic SASI has shown to be an effective, safe, and simple procedure for the treatment of morbid obesity and associated metabolic consequences. Moreover, it results in minimal post-operative nutritional complications in comparison to the other bariatric procedures. These are the few papers from the United Arab Emirates. This Mehdi, he has performed a lot of SASI, almost 150, 75. And in his paper, he said that it is a promising procedure and no malabsorptive absorption morbidity. The elimination of 2 ways for passage of the food decreases nutritional deficiency. The technique leads to early satiety due to the intense stimulation of the distal gut hormones activity of the proximal bulb. Hormones like GLP-1 have vital steatogenic impacts. So you can see here, and this is first we have to do sleeve gastrectomy. Later on, we bring loop of ileum and we count from the cecum, and about 250 to 300 centimeter, we bring it to the pylorus and we anastomose to the distal. That is the common in this channel, 250 centimeter. Another picture, you can see it's easier than this MGB, or you need to do sleeve, and it's called sleeve plus procedure nowadays. Okay. And I'll show you this video. You can see we are just doing that. We are doing sleeve gastrectomy. You have to open lesser. Go up till the angle of it. The most important point while doing sleeve is short gastric area. You have to be very, very careful of short gastric area because you can end up with now, the most important point is we have to almost 6 to 7 centimeter away from the pylorus. This is a pretty. So we have done our sleeve, and now you can see we'll measure almost this. We are dividing momentum over the transverse colon so that it's easy for us to bring small ball. You have to divide this one, otherwise it's difficult to bring small ball up to the level of pylorus. Welcome, Dr. Imran. Nice to see you.
Dr. Maaz, excellent. You are excellent, and thanks a lot for invitation. Sorry because I was busy early morning in operation room. Just I have joined and I think I have missed some presentation.
Yeah, thank you very much. Now we have brought that small bowel up in the first stage. PDS 0. नहीं पीछे या पीछे नहीं स्लाइड आगे नहीं करनी थी पीछे करनी वीडियो आपने हाँ इसको आगे ले जाओ so I think we are supported. So we are just at the end of our anastomosis. You can see how beautifully that loop has joined this one pylorus, now gastrointestinal, almost 200 centimeters we have.
Maaz, you did not use any staples. You're just doing direct.
Actually, we skipped that now. I've used stapler.
What size stapler do you use?
This 60. I use 60.
60 gold
blue.
Or 60 purple?
Blue. 60 blue.
60 blue. Right, thanks.
Yeah. Previously, I was using 45 in 20-30 cases. Then, because sometimes it slides 1 to 3 or 5 millimeter, it slides vein. So that's why I use 60. Even if go back, it goes to 50. So it's safe to use 60. So this is the, I think, picture at the end of the operation. You can see. So these are the things. Hormonal changes are maximum and less malabsorption. There's less hypoglycemia. There's less dumping. It's easy to reverse. Better than SASI and urinary switch. No gastric remnant. Access to the biliary tree is maintained, and less risk of internal herniation.
Sorry, what was the length of your bowel from Ileal?
300 centimeters. Somebody who is more than 150, I use almost 250, and rest of them I use 300 centimeters. Now, but in after 100 cases, what I have discussed with other people who are doing SASI, now I count total ball, and I bypass almost 55% of that. So with that, you get better results. Out of like 55, 45, you have to divide it. If you count total ball length, you do that. So this is my paper, almost 200 cases of this one SASI with sleep gastrectomy with type 2 diabetes. So they were of 20 to 60 years of age, and patients were previous. They had a few of them. They have history of bariatric surgery, and diabetes. Complete remission was considered with HbA1c less than 6, and no anti this one oral hypoglycemic medication they were not using after that, and we got very good control in just 2 months. HbA1c it's just gone down from 11 to just 6 or 7, and after 6 months they went back to 5. We have few patients, they were having insulin, very uncontrolled diabetes of HbA1c 13, and in just 4 months they came back to almost 6. So I'll show you can see this is the age group 20 to 30 years. We have got this 11.5%, 31 to 40 we have got 39.5, 41 to 50 we have got 87 and 42.5%, 51 to 60 we have got 5.5. We have got 200 patients, and remission of diabetes was excellent. Mostly I choose patients who have got uncontrolled diabetes, even with their oral hypoglycemic agents, HbA1c more than 7.5, and what I have seen, even after as using a second procedure, this is also better. Like after sleep gastrectomy, somebody who have gained weight and have got very, very good results by doing SASI in them. So according to gender, we have got almost 83%, 41.5% male and 58.5% female. So range of HbA1c 6.5 to 7.5. There were about 5 patients, 7.6 to 8.5. 27 patients, 8.6 to 9.5, 59, and 9.6 to 10.5, 89. Above 10.5 were 20, total were 200. So after surgery, diabetes was controlled almost all of the patient, but among 3 patients, I had to reverse SASI. It's very easy, believe me. You have to take just 10-15 minutes. I had to reverse because these patients, they got their landmark to achieve their goal. From 130, 40, we came back to 75 and 80. And so they were comparing that maybe they are going to lose more weight. And HbA1c was very much controlled from 10.5 or 12.5 to less than 6. So that's why I just went in and I just reversed them. 2 of them, they have got some nausea, on and off, some reflux. Almost they are doing well. So that's why I had to reverse 3 of them. So it is preferred technique due to its effectiveness and simplicity as well as a low rate of complication. Finding Maaz study also indicated that more than half of the patients, 58.5 of the patients were females and 41.5 were male patients. HbA1c, blood glucose level for the last 2 to 3 months are believed to be the most reliable measure of the glucose metabolic control. So 8.5 above it was 5, 6, and 12 was most enters the duodenum. The anti-incretin effect is intact, and consequently the risk of hypoglycemia and dumping syndrome is less. So a few of the slides before and after. This you can see he was 145, now 75, 150 to 80, and 155 to 75. Very this 145 to 30. Again, this guy, he was 144 and he is now almost 90 kg. HbA1c was 10.5 or 11.5 something, and now it is 5.5. He has got some reviews. We'll just play.
हाँ जी बिस्मिल्लाहिर्रहमानिर्रहीम हमारे पास शाहिद है मेरे पेशेंट फैसलाबाद से इनका वेट 142 kg था और डायबिटीज़ बहुत ही अनकंट्रोल्ड HbA1c जो शुगर का 3 माह का टेस्ट था वो 10 पॉइंट समथिंग था और अभी 10 माह हो गए हैं तो इनका मैंने लेप्रोस्कोपिक सिंगल एनास्टोमोसिस स्लीव इलियल बाईपास किया है जो सासी प्रोसीजर के नाम से है और इस वक्त वो शुगर वालों के लिए बेस्ट ऑपरेशन है पूरी दुनिया में और इनका वेट ऑलमोस्ट 50 kg कम हो गया 10 माह में। तो अब जो रिसेंट इनकी जो HbA1c है वो तकरीबन 5.4 आ गई है और आप ये देख रहे हो आप स्क्रीन के अंदर कि ये 5.4 आ गई है। पहले मतलब कहाँ से ये चले थे तो ये जो लास्ट वाली थी अब आप देख रहे हो स्क्रीन के अंदर इधर 8.2 थी, उससे पहली 10 वाली थी। तो मैं शायद से पूछूंगा कि ये कैसा फील कर रहे हैं।
जी अस्सलाम वालेकुम जी, बिल्कुल जी। मैं माशाल्लाह सबसे पहले तो अल्लाह ताला का बहुत शुक्रगुजार हूँ, तो उसके बाद मैं डॉक्टर साहब का बहुत बहुत मशकूर हूँ और शुक्रिया अदा करता हूँ कि मैं ज़िंदगी एक बार मिलती है तो मैंने आज वो सबक सीख लिया है अपनी ज़िंदगी इंजॉय करने का कि जैसे मैं डॉक्टर साहब के पास पहले 10 माह पहले आया था तो बिल्कुल 10.2 मेरी जो HbA1c थे और आज मैं 5.4 पर हूँ। मैंने ग्रुप में भी अपने शेयर किया था तो मेरा जो वेट था 142 था और आज मैं 94 माइनस पर हूँ और मेरी वेस्ट जो है वो 48 थी, अब माइनस होकर मैं 36 वेस्ट पर आ गया। इतनी वेस्ट तो मेरी शादी पर भी नहीं थी, तो अल्लाह का।
So this from the literature. Thank you very much, and the topic is open for discussion.